Thank you so much for your patience. You really know how to get a group of people out, and you really know how to be patient. There was some trouble with the power here in the room, and that threw off the sound system, and so that's what we've been making sure that we have adequate sound for the whole meeting tonight. So thank you very much. And welcome to Better Access, Better Care. It's a community meeting sponsored by the Department of Health and Wellness and in partnership with Health PEI. My name is Carol Gabbana, and I'm a private consultant in Charlottetown, and I'll be the moderator for this evening's meeting. And the format for the meeting will be presentations from Minister Doug Curry, the Minister of Health and Wellness, a presentation by Dr. Richard Wedge, who's the Interim Executive Director of Health PEI, presentation by Jeff Waring, who's the Acting General Manager of Island EMS, and by Marnie McCrae, who's the Manager of Recruitment and Retention, and she'll be talking about physician recruitment and retention. So following the presentations then, there will be time for questions and answers, and I'll talk about the question period a little later on. I want to point out that you can kind of hardly see over on the side here, there are some booths with lots of information. So after the evening is ended, then you may want to wander over and gather some information there. And we will, because we were late starting, we will be finished by 9:15 this evening. So I'd like you to help me welcome now Minister Doug Curry, the Minister of Health and Wellness.
Thank you very much, Carol, and it's great to see a big turnout tonight, which I anticipated, and I think at this point there's two really positive things about this meeting so far, that there's a ground ambulance out front in case I need one, and the back door is open. So with that being said, I want to share a few comments. I've had the opportunity to be the Minister of Health here in the province of Prince Edward Island now for the majority of my time in politics. And I think at this point in time, I've had the opportunity, I am the longest standing health minister in the country, so I've had the opportunity to see healthcare not only from a regional perspective, but a provincial perspective, but also across the country. And certainly, as we talk about healthcare, I think it's very important that we continue to look at the big picture realities and what's facing the challenges here in the province of Prince Edward Island. And there's two issues right now, the trends that we're seeing here in the province of Prince Edward Island. One is that we've got an aging population that is going to require services and a range of needs moving forward. And the other one is that we've got high volumes of chronic disease, and that's been validated by the Chief Public Health Officer's report that we're trying to manage every day in communities across Prince Edward Island. With that being said, since coming into government, I as the minister, when we came in 2007, our provincial healthcare budget was approximately $360 million. Today, our healthcare budget is and will exceed $570 million. So the challenge for myself as the minister, and when I see my overarching responsibility, and that's looking at services across the province of Prince Edward Island. And as the minister, I have the ability to see levels of access, the number of people that live in this community or live in communities in and around the lining areas that access services not only in this community, but access services in Kings County Memorial Hospital and access services at the Queen Elizabeth Hospital, and also use services at a province, which is a $50 million budget, which is the second largest hospital that we own, but it's out of the province, even larger than the provincial hospital in Summerside at $38 million. So healthcare is a personal issue. It's an emotional issue. Healthcare, the roots in hospitals and facilities run deep in communities all across Prince Edward Island. And certainly as the minister, I respect that. But at the same time, I have the constant pressure and challenge to make sure that we try to provide services and meet the needs in communities all across Prince Edward Island. And that's a difficult responsibility. And even with 43% of the overall provincial budget, there's still ways that we could find to need more money and spend more money. The challenge with our healthcare budget here in the province, the more we spend in healthcare, it's going to continue to chip away at other government departments and resources and services. Today in the province of Prince Edward Island, we have more physicians than we ever had. We've got more nurses than we ever have. more LPNs, more RCWs. We've expanded the scope of practice for our nurse practitioners, our LPNs, our optometrists. We're working closely with our pharmacists to do different things in communities across Prince Edward Island. So it's an ongoing challenge. It's an issue that is a very difficult responsibility. And meetings like this are certainly opportunities to hear from the communities, obviously to share some of the pressures and some of the realities that we're being faced with. But I think tonight it's your night. It's not about Doug Curry tonight. It's about you. It's about your community. It's about an opportunity to ask questions. I'd certainly ask you to keep an open mind to look at what this presentation is about, and it's real good clarity on the services that will continue to remain and why we need to continue to use the hospital here to its full capacity and make sure that the hospital is moving on all 4 cylinders every day of the year, 365 days of the year. Currently, right now, if you look at the occupancy rates here in the facility, I think last year we used 72%. We were at 72% of full occupancy, which is a bit of a challenge, particularly when you've got approximately 12 to 15 seniors or children on stretchers in the hallways at the QEH waiting for an acute care bed because we've got seniors or medically discharged patients that don't have a bed in Charlottetown looking for placement. So some of that information will be shared tonight. I'd ask you to keep an open mind. I'd certainly, I'll answer questions if they get to be really clinical. I'll certainly ask some of the experts and some of the clinicians. I'm not a doctor. I'm a politician, and my job here tonight is to get the information and the accurate information out to not only this community, but communities that we move into over the next number of weeks to get the information. So there will be short presentations, but most importantly, there will be lots of opportunity, and we'll be I thank you very much for coming out tonight. It's a very important meeting, and I look forward to the conversations and the information sharing back and forth. Thank you very much.
Thank you very much, Minister. So I'm going to go through a short presentation as well. Hopefully everybody can hear me. No? Turn it off? No? Speak closer maybe? Is that? Yeah? Okay. So I'm going to give you a presentation of sort of how Health PEI is going to approach some of the changes that are occurring within the health system all across PEI. So as the Minister was saying, we intend to completely use all our facilities to their best capacity, and that includes the Souris Hospital. It still will remain a hospital within the 7 hospitals here in PEI. In summary, I just wanted to clear up some of the information that's been in the paper that about what services are going to be remained in PEI, in Souris, sorry. So, contrary to some of the things that were in the paper, lab and X-ray services are going to remain in Souris. Ambulatory care, which things like IV, blood transfusion, some injections from some of the nurses will continue to be at the Souris Hospital or the Souris Clinic, depending on what's more appropriate. Souris will become a specialized extended care hospital looking after patients who still need 24-hour nursing care, as well as some what we decided to call today. Actually, I met with the physicians just before coming here. Instead of calling them acute care, they're going to call them a subacute care, which is essentially what they're doing now. So we'll get into that more in a minute. There's going to be a new rapid response unit that people are going to hear about a little bit more from Jeff from Island EMS. We're going to continue to expand access to primary care here in Souris, although as everybody knows, it has been a bit difficult with 2 physicians and our nurse practitioner that's currently in the area. Walk-in services are going to continue to occur as we have the staff to do them. And then, of course, government has announced a new 811 telehealth system, which is a 24-hour nursing line for people with health concerns that they can get health care advice, which is a new thing. So those are sort of some of the summaries before we get into the presentation. So again, facilities will have acute care facilities. We'll have specialized extended care hospitals. We have a number of manors in PEI as well. So I just want to point out that an extended care hospital requires people who still need hospital care, still need 24-hour nursing care. This is not a manor. Extended care is not manor care. So basically the way we're looking at this from a healthcare system is acute care are people who are acutely ill, they're short of breath, they're unconscious, they have epileptic seizures that are prolonged. These are people who need access to monitoring beds, they need access to physicians 24 hours a day, they need access to ICU, they need access to specialists in general. So that's what we mean by acute care. Extended care are people who need restorative care, whether they have mobility problems following a stroke, whether they have convalescent problems post-operatively, they may have a hip infection, they need some IV antibiotics, those are convalescent. People who have palliative care, who need end-of-life care, people who need a bit of rehab, respite care that's currently offered in the Souris area as well, as a lot of you probably know, to allow some families to have a break when they're looking after somebody at home. So those sort of care, what we call alternate level of care within the healthcare system, are all what we want Souris to specialize in. Now, those types of care are going to be occurring in all 7 hospitals in PEI. There will be alternate level care patients within Summerside's Hospital, within the Charlottetown Hospital, O'Leary, and Western Hospital as well. So again, just to reiterate, extended care is not a manor, despite some of the emails and letters that I've gotten over the last few weeks. So to go back to what the government announcement was a few weeks ago, Stewart Memorial Hospital will become a 23-bed manor. That is, they will not be an extended care hospital that we're talking about here tonight. Both Community Hospital O'Leary and Souris into the O'Leary meeting yet, but the O'Leary Hospital has been an extended care hospital. This is really where this concept developed and has been for the last couple of years, led by Dr. Grimes in O'Leary. Western Hospital and Kings County Hospital will continue to provide acute care, and by acute care, they're supporting the emergency rooms to make sure that there's going to be beds available for people who go to the emergency room, that there will be a bed for them to be looked at in the hospital. And then Prince County Hospital and Queen Elizabeth Hospital will remain our specialized acute care hospitals, and obviously that's where the specialists work for their day-to-day work. Where the people in the Souris area go now, the people in Kings County go now, area roughly 60% of them. 60% of the people in Kings County are admitted to the Queen Elizabeth Hospital for acute care now, and about 24% of the people in Kings County are admitted to the Kings County Hospital for acute care now. So about 16% are admitted to the Souris Hospital for acute care. So essentially 84%, there won't be any change at all. This is some of the reasoning behind why this change is needed to occur. These are numbers of people. In the blue are the people every day waiting at the Queen Elizabeth Hospital for care. So what happens here is when you go to the emergency room at the Queen Elizabeth Hospital, a decision is made to admit you to the hospital. There is no bed for you. So 11 to 12 people every day are receiving their care in the hospital on a stretcher in the emergency room because there's no bed to put them. So that would be equivalent of coming into the Souris Hospital and being kept in the old outpatient department on a stretcher rather than in a room where you can be cared for properly. And as everybody knows, it's not great care to be receiving care for 3 or 4 days on a stretcher. The ones in the red are the Prince County Hospital. There are 2 to 3 people every day who are being cared for in a stretcher in the emergency room there as well. This slide is to show everybody what is happening at the Queen Elizabeth Hospital and Prince County Hospital again in terms of alternate level of care, so people who no longer need acute care. In blue are the people that are receiving acute care, and in red are people receiving the alternate level of care. So the Queen Elizabeth Hospital, the bars on the immediate left, have 70 acute care beds, and at any one time 29 of those are people who have finished having acute care but no longer have a place to go. And these are the patients that we'd like to be sending to both Souris and O'Leary. Prince County Hospital have 34 acute care beds, and about 13 of them at any one time are receiving alternate level of care. As the Minister pointed out, this is just a slide around the occupancy rates at Souris Hospital. So in 2010, 2011, 2011, 2012, so with roughly 72, 74%, 75% of patients last year were occupying the beds, which means that there are 5 to 6 beds at any one day that are empty and yet staffed by nursing staff and physiotherapy, etc. But there's nobody in them. What we want to do is put people in those beds. There are also some improvements to emergency care that Jeff is going to go over in a few minutes as well, but we are adding an interfacility transfer unit. These are to transfer scheduled patients between hospitals so that we don't have to take our ambulances out of service, and they're available for emergency response to improve our response times for ambulances. So that's the interfacility transfer unit. And then 2 rapid response units, one which will be stationed here in Kings County, either in Souris or in Montague, depending on the need for the day, depending on what the ambulances are and what's being called out. There was some rumors at one of the other meetings that this rapid response unit was going to be in Hunter River. That is not true. The rapid response unit will be in Kings County, either in Montague or Souris, depending on the need. There's been some question as well about the long wait times at the Queen Elizabeth Hospital as well, so I put the slide in for people. The blue bars by month are people who are at the Queen Elizabeth Hospital for true emergencies, and these are people with chest pain, active bleeding, severe lung disease, that kind of thing, what we would call true emergencies. There is just under an hour wait at the Queen Elizabeth Hospital for these types of patients. Then when you look at the red bars, which are essentially what we would call family doctor visits, these are people who need prescription refills. You may have a bit of a fever, sore throat, that sort of thing. They're usually in the emergency department because they don't have a family doctor, or they can't get into their family doctor, or it's after hours, or it's a holiday, and that kind of thing, which is why they're at the Queen Elizabeth Hospital, of course. And their waits average about 2 hours. So, as everybody knows, there's lots of times. Yeah. So as everybody knows, that there are averages with everything. Sometimes it's faster, sometimes it is slower, and there are days that there are longer waits. But this is the true data that's generated by the hospital on a regular basis, and it's given to the emergency department staff. So again, the 811 telehealth system will be a 24-hour response line that people can call and it'll be answered by a registered nurse about any particular health concern they may have, whether it's about a certain disease or a child with a fever or those sorts of things. And they just want to know what to do, whether they should wait for the next day or go to an emergency room, or whether they can treat them at home. The other advantage of this system is that it will be available in multiple languages as well. These are some of the examples that we've been using about why we're doing this change to care. This first example is a 94-year-old lady who was seen in the emergency department around midnight or so, needed admission to hospital, but there were no beds, refused to stay on the stretcher and wanted to go home. Over the next 4 months, there were 4 other visits to the emergency department, still no bed for this lady, and she received all her care on a stretcher in the emergency department. And from a health PEI, from a clinician point of view, we don't feel that it is acceptable care at all. The other one is an example of a man who fell off a ladder and broke his upper arm, fractured his arm. There was no bed available in the orthopedic beds at the Queen Elizabeth Hospital, and no trauma time at the time for the orthopedic surgeon. So they waited from Saturday until Wednesday in pain while waiting for a bed. And that there were beds available elsewhere within the system. We just have to move the patients around. Another common question from people in the Souris area is will our doctors be able to admit patients? And the answer to that question is yes. The physicians are still going to be admitting to the Souris Hospital. The patients have to be looked after by a physician. As I said, I met with the physicians before coming here today, both Dr. Henbest and Dr. Burrow, and we had a discussion around the admission criteria and how this is all going to work, and they were very much in agreement that this is essentially what they're doing now, that they send their most acutely ill patients to either Montague or QEH depending on the need for the care that they need, and they still will have beds to admit to. So we're going to embark on a little bit of a study for them just around how many of those beds they want to set aside for that, what they don't want to call acute care because it's not acute care, so we're going to call subacute care. But it's essentially what they're doing now with patients in the Souris area that obviously are well known to them in their practice. So the final sample that we have is another question that came from the Souris area by email the other day about a mom who has congestive heart failure and lives in the Souris area. She lives in the Charlottetown area, and essentially this lady lives alone and needs to be admitted every now and then because her congestive heart failure gets out of control. And of course the answer to that is that if the physicians feel that that's the place to be, that they will be admitting her to the Souris hospital. So I just wanted to put that example out. This lady may well be here in the audience tonight, for all I know. I have a little bit of a cold, so hopefully my voice will last. This is just a bit of a cartoon to show that the red dots are there. You probably can't see it from the back of the room at all. Sorry, it's a bit of a cartoon to show where some of the issues are currently within the acute care system. The red dots are things that aren't really working that well that we're trying to make some improvements on. And so essentially what this is saying is that the patient goes to the hospital emergency room. In general, they're seen, they're admitted to a floor. There are issues with the length of stay in the hospital and whether or not they can get out of the hospital in a timely manner. There are issues around discharging them home, having the right amount of home care available, whether they have long-term care bed available for them if that's what they need. But obviously if they need to go home, usually that's a straightforward thing. The red dots that are on the lower half of the thing. Let's see if I can get this pointer going here. Maybe not. Anyway, the lower half from the H going downwards are people that are waiting for elective surgery who are being blocked because the surgeons don't have a bed to put these patients into. So what ends up happening is they have off-service medical patients in the surgery beds, and the surgeons have to say to the patient, no, your surgery is going to be delayed, or we can't get you in for another couple of weeks. So this is basically a diagram of what we hope the future state will be, that people go into the hospital, they'll be admitted into the medical floor, they'll stay the appropriate length of time, they'll be discharged to a hospital that meets their needs, and then either go home with home care, or into a long-term care bed as the need may be, and that the surgeons will be able to admit their patients on a timely basis and get their surgical wait times down to what's a more acceptable level. So I'll put the summary slide back up just to so people will realize while we're changing speakers here. So we'll answer some of these questions after we're done here. So, Jeff?
Good evening, folks. My name is Jeff Waring. I'm the Acting General Manager of Island EMS and Medicom Atlantic. I've been asked just to kind of go over a review of how our system works and some of the stats that we have. This is a basic map of Island EMS. As you can see, we have different posting sites, and we have our bases in Surrey, Montague, Charlottetown, Summerside, Alberton, and O'Leary. And along the way, we have different posting sites, and those posting sites are there depending on our system status plan. We have 14 ambulances on PEI during the day. Any given day, we do 6 off-island transfers to Nova Scotia. And Minister Curry mentioned that when he talked about the expense of that. So besides doing that, we have to accommodate transfers, interfacility transfers from Surrey Hospital, QEH, back again, and around to the other community hospitals. So depending on how many trucks we have in the system that aren't responding to emergency calls, we strategically place them. And that's dynamic throughout the day. There can be times when it's very quiet and we have lots of ambulances. And then there are times when it gets really, really busy. It'd be a weekend, typically our busy times, and we're hit with an awful lot of calls. Presently, we do 13,400 calls a year, which is greater than 1,000 calls a month. We predict that that's going to be over 14,000 calls next year. So it's continuously growing, And as the baby boomers, myself included, get older, we're going to require these services more. So basically, I mentioned I was acting general manager of Medicom Atlantic, and that's our dispatching service. They took over very highly trained individuals who take your 911 calls and direct them to the appropriate facilities. It starts there. As soon as you pick up a phone and call 911, it's immediately traced where that call comes from, and they can start the ball rolling, and they will actually activate the paramedics once they know the general area, and they'll say, for instance, Surrey 5-3, please start rolling code 2 to North Lake. Before we even have the medical information, so they're off and rolling really quickly. They do a really good job. Paramedics are trained to assess, manage, and treat people. It's gone great leaps and bounds. I spent many years working here, actually for Gerard Holland, who took the service a long way. 13 years ago, there was probably 2 or 3 advanced care paramedics in PEI. At this point, we have an advanced care paramedic or an intermediate care paramedic on every one of our scheduled ambulances. So that's how far we've come. Advanced care paramedics can treat everything from congestive heart failure to cardiac arrest to respiratory distress. They have expansive training in pharmacology and cardiology, and are as good a paramedic as any across the country. They're very highly trained people. Intermediate paramedics are a step below that. They can still do a lot of the cardiac stuff. They can do administer narcotics and stuff like that for pain. So they're very highly trained as well. And the next step down from that is a primary care paramedic. And those are the basic life support. They can administer drugs for cardiac as well, basic drugs for cardiac. And they can give some respiratory drugs and allergic reaction drugs, things of that nature. So those are our primary care paramedics. And usually we run with either an intermediate care paramedic and a primary care paramedic, or an advanced care paramedic and a primary care paramedic. They all have online medical consultation. They have instant access to physicians in all the emergency departments, so we can quickly get on the phone and consult with physicians across the island and get directions if we have any questions and or get advice. And again, I talked about their extensive scope. Enhancements. These enhancements that Minister Curry has announced today are going to make a fairly significant impact on our service. Presently, what happens if you have to transfer a patient from Kings County down to QEH for typical testing, they last an hour for an x-ray or something of that nature, we take an emergency response system out of our system. So what we do is we take that truck and it goes and does transfer. So it's no longer available for emergency call. And depending on how busy our hospitals are, transporting patients obviously dictates how many ambulances we have on the road. This ambulance that Health PI is announcing is going to be outside of our SSP, our system status plan. So it will be scheduled so the nurses and doctors at Surrey Hospital will be able to take that ambulance, book it, and that ambulance will just do that call. It will not respond to emergency calls, which will take a significant load off of the other ambulances in the system. The other one that we're talking about are the emergency response units. Those will be in Eastern Kings. They will be staffed with an advanced care paramedic with actually a little bit more training. They will have a direct line to physicians, an online physician to consult. And essentially, if our system is busy or that ambulance or emergency response unit is in the area, we can quickly dispatch that so treatment can start, and then another ambulance can come in and alleviate and transport the patient. It also works really well in typical things that most people wouldn't think about, like lift assist. If if we need a lift assist, we usually have to call for another ambulance. That ties up 2 of our ambulances. And generally, like I said, if we only have 9 at night and 14 during the day, that's a significant thing. So this unit will be able to alleviate that stress as well. The interfills, I've talked about that. One of the things that we see is, and Mr. Curry mentioned it, it's the backflow. Patient flow doesn't work really well. So we get offload delays. They've gotten a lot better, and we continue to work really diligently with our stakeholders, LPI and the hospitals, to try to improve those. But that's a direct correlation to bed flow. As soon as it starts backing up from the top of the hospitals, there's no place to put the patients in emergency, and that's where we get the patients in the hallways and offload delays, etc. Some of the stats, just a few stats. Surrey had about 725 calls. We had exactly 725 calls last year. We had 13,400 provincially wide, as I stated. So that's about 5% of the calls go to Surrey. 331 of those were emergency calls. 151 of those were urgent calls, which would be transport without lights and siren. And 242 are interfacility transfers, which generally are routine scheduled transfers. And you can see where our 90th percentile is a benchmark that we try to achieve. And in Surrey, it's at 2359 for our emergency calls. And that's the whole area of Surrey, not Surrey town sites. And you can imagine when we have to travel to North Lake or South Lake, that takes a bit of time to get up there. And the areas around it, and 30 minutes for urgent, and that's 90% of the time, although there will be anomalies, and we are very aware of that there are times when it goes above that, and there are times it's significantly lower than that. Thank you very much.
Good evening. I'm Marnie McCrae. I'm manager of the Recruitment and Retention Secretariat under Department of Health and Wellness. And I've been working in this role for about 3.5 years. And in my time in the role, physician recruitment has certainly been a key focus of our division. We have a physician recruitment coordinator who does recruitment for physician specialists across the province. And some of the challenging areas that we found have been specialists, oncology, physiatrists, those types of specialists that are really hard to recruit, and also the rural family physicians. But I guess we're not alone, because all my colleagues across the country are saying the same thing. We have lots of challenges when it comes to rural recruitment. So just to kind of run through quickly for you, we have a complement in Surrey of 4 physicians, so we have 2 practicing physicians, 2 vacancies, and we have our nurse practitioner. We've done a lot of investments around recruitment over the last number of years. And I looked back in our statistic to see how many site visits have we brought to Surrey in that time period. We've had 28 physicians come for a site visit. Now, when we do a site visit, it's comprehensive. We bring in the physician, their spouse or partner, if they have one that wants to come along. We take them out to meet with the schools. We take, if they have children, so that they can see the community. They tour the facilities, the community. They meet with real estate while they're here. So we make sure that they get a really good sense of what the community's all about. And they're meeting with the physicians within the facilities at that time as well. So if we're looking at 28, probably site visits during that time period at about 3,000 per visit, that would be an 84,000 investment to this community, just specifically with the site visits. And we've looked at locums. So for you folks, you know you've seen a lot of locums come through this area. It's challenging when you see locums coming in and out. We know that from a continuity of care. But they are providing a valuable service to this community, and there's been 63 over that 10-year period that have provided support. So I just wanted to talk a little bit about some new opportunities and to give you a sense of what we do have for incentives. So for our rural physicians, someone coming to one of our rural communities, today they receive a $35,000 return in service commitment and investment. So that means they say, we're going to come, we'll stay for 3 years, and over that 3 years, they'll receive those payments. They also receive $10,000 to $20,000 in moving expenses. So I'm very fortunate to have a very competitive budget to be able to do those kind of incentives, which are very similar to cross-country. The other area that we've done just recently, we've said, okay, what can we do for West Prince and Surrey? These are our two most challenging areas from a rural physician recruitment right now. And so we've put out a request. We've got an excellent new program over the last 3 years, which is the PEI Family Residency Training Program. So that program is bringing physicians back to do their last training, their family physician training right here in the province. So they're here for their last 2 years of training, and we're seeing great return on those folks when we're doing the training with them. Most of them are deciding now we're going to stay in PEI. So we put out to those folks, we said, if you decide to stay in Surrey or West Prince, this is over the last 3 months we approached them, would you consider a $50,000 signing bonus? They didn't accept it. We gave it to them, we gave them the opportunity, they did some thinking about it. They didn't accept it, but we gave them the opportunity. So then we went out to all those folks who are currently PEI residents, who we know of who are out in all other Canadian universities, who are in that same last year of training and ready to complete. And none of those accepted the offer as well. So it was disappointing to us. We'd really hoped that that was going to be an opportunity that would bring someone here for you folks. So we're evaluating that right now. We're not sure what that says to us. The other new program, the minister talked about it in the legislature, I believe yesterday, that our applications are now available for our new family medicine sponsorship program. This program is going to be available to students that are completing their second year of training in medical school. So we've heard from students who have connections to PEI. We want some funding as we're going through our training. Is there anything you can do for us as we're going through our training? So we'd offered this up to students to do some long-term planning. And we're focusing this program on the area of greatest need. So we're not telling those folks where it is they're going to practice at this point because they're completing their second year. So they've got a number of years left. But if they'll sign a commitment to us in their end of their second year that they'll work in one of the area of greatest need in the province, then we're going to provide them with funding over this time period. It's $110,000 that they will receive to support their education. So the applications close mid-May, and our fingers are crossed that we've got some good applicants. We're doing lots of advertising, so we're really hoping to have some really good competition for those funds. So I just want to kind of let you know what we're doing today, what's happening today in recruitment for Surrey. So we've got ads out just recently over the last month. These have gone out in the Just for Canadian Doctors magazine, Medical Post, Canadian Medical Association Journal, the Canada MD website. So we do lots of advertising to get the word out that we're looking, not just in Canada, but internationally as well. We attend job fairs. We have one coming up in May, and my staff are going to be going to the Primary Care Today conference where there's 2,400 physicians going to be present there. So we're going to recruit, we're going to have a booth there and see how we make out at that conference. So as I said, we've got competitive incentives. We have our applications closing next month, and we're really hoping that something good happens with that. The Retention and Integration Committee, as I'm sort of completing these comments, any folks here involved with the RICH Committee? I'm thinking we might have a few people here involved with the RICH Committee. This is a piece of work. So retention, we know, can be a challenge in our rural communities. So we want to see what can be done to support retention. And we need the community involvement. And Newcomers Association received funding through an Atlantic committee I'm involved with for internationally educated health professionals, and Health Canada provided funding through to that committee. And Newcomers is out. They have a committee. Now, it started in Summerside. It's rolled out down here, Montague, Surrey, and it's also going up to West Prince next. And the committee involves the community, involves education, and it involves health folks. And we know that if people, research has shown us, if people feel connected with their community, that they're going to stay. So that's what we want. We want physicians who are going to come and who are going to stay. So we need community involvement in that too. So thanks for your time.
Okay, thank you for all your information to the speakers. And now it's time for questions. So a couple of things that I want to say about the questions. There's a microphone right up here at the front, so I'd ask you to come to the mic so that you can be heard. And would you please say your name, just so we know who you are. The responses, as the minister indicated, will be by the minister or by Dr. Wedge, or there are other staff of Health PEI here as well, so if they happen to be the person that has the information that could respond to your question, they are ready for that as well. The other thing that I want to say is that I know that this is an important issue for you. Health and healthcare is an important issue to all Islanders, and I can tell by the number of people who are here tonight and who are here early. I thought I was going to be early, and there were a whole bunch of people that got here ahead of me. And often, my experience would say that when there is an important issue, emotions can sometimes run high. So I'm requesting that everyone just be respectful tonight, and part of that includes noticing if there's people lined up waiting to speak, like this gentleman is here, and just don't take up all the airtime. Make sure that everyone who has questions is able to ask their questions before we're done this evening. So we'll wrap up the questions at 9:15, and I will invite this man that's there right now. You can start.
Test. Hello. Friends and neighbors, government members, my name is Alan McPhee. I'm a member of the Island-wide Hospital Access Committee as well as chairman of the local Island Hospital Access Committee. I have a few comments in that capacity for the minister and one question. And don't worry, we are civilized people in this community. So. It's very difficult to articulate the closing of rural health centers and loss of service that we've experienced over the last decade in the few seconds that the minister has chosen to allow us to speak. But I do ask for about 500 seconds to do that. I will comment on the values of what is going on, and I know there's other people in the community and on our committee with specific questions. The decision to not engage in public input is a reflection of the idea that what people have to say is of little value, and the proposal to continue to cut healthcare services outside of Charlottetown reflects little regard for the value of people, which is contrary to our rights and worth as individuals and as a community. I realize the minister has a background as a school principal. I know him personally. I respect him personally as a good man. However, he would be well advised to understand that island-wide hospital access will not line up like a child on the line and walk to our demise. We are available for longer discussion at a public round table at the minister's pleasure. There are three problems with this proposal. The first problem is it makes no sense from a healthcare or economic sense. All communities want basic health care. The College of Family Physicians lays out the principles of patient-centered health care, and the patient-doctor relationship is at the center of that relationship. And the basic health care that people want is a relationship with a doctor, and a doctor who has sufficient emergency and specialist support. The chronic conditions best described by the minister as driving this proposal, such as diabetes, is best served by a close relationship with a physician, not in the trauma of transport. There are numerous medical studies in peer-reviewed magazines that show that the best health outcome at the lowest cost to the system is health that is done close to home. In Saskatchewan, I know the minister makes note of his experience on a national level, and Premier Giz is co-chairing with the Premier of Saskatchewan the National Healthcare Committee. In Saskatchewan, they went to a centralized super hospital model. It failed. They're now building rural hospitals in Saskatchewan. And if the minister and the premier are in tune with what's going on nationally, just lean over and ask your co-chair what's going on in Saskatchewan. While I empathize with the 94-year-old woman laying in the hospital in the QEH for 4 hours, I note the difference is that in Souris she would have to wait an hour for an ambulance and be transported an hour to an hour and a half, if that's possible, given the weather we have up here. And it's a simple point. We encourage improvements at the Queenie. We require specialist care at the Queenie, but you do not have to eliminate rural health care to do it. We're told the budget grew from $250 million to $570 million. It's about 4% of the health budget to run rural health care, about 11% if you include the Summerside Hospital. The best data we could get is there's somewhere between 5,000 to 7,800 employees on the health payroll. And I don't have verification of that, but is that correct? 4,500. So that's about 1 for every 32 people. That would, on a per capita basis, in the Surrey Hospital region, that would be about 180 people working in health alone. So, and I noticed that even though they have 4,500 employees, we still had to have a consultant hired to run this meeting tonight. And I would like to know the cost of that payroll. I expect the payroll for bureaucracy on PEI exceeds the budget for rural health care. I think the budget is out of control because the minister does not have a handle on it, and the priorities are upside down. PEI is the most rural province in Canada, yet we have another government driven by debt-fueled centralization, and the values of sense, of safety, and of decency have been banished from PEI by the unsustainable addiction to centralization. Deputy Health Minister Michael Main was reported at a public meeting to say the future of PEI is 100,000 people in the Charlottetown region, and there's no consideration for the people that are planned to be deported to the city. This is the same guy that spent somewhere between 100 and 200 million, what difference when it's hundreds of millions of dollars, on a biopark in Charlottetown that didn't work. Normally you lose your job for that. He got promoted to Deputy Minister of Health. Deputy Minister Main's theories are out of touch with the reality of living in the most rural province in Canada, and he should be released from his role as Deputy Minister for misguided incompetence. And as for the notion to build a long-term care facility in Charlottetown so all acute services can be handled in the Queenie and the Prince County Hospital with the eventual closure of Alberton and Montague, island-wide hospital access, the people and the communities we represent say no. The second reason that this proposal is at fault is because of prejudiced discrimination. Despite Prince Edward Island being the most rural of all Canadian provinces, rural discrimination abounds. The Souris area, because we receive approximately $3,000 per person in federal transfer payments, makes $18 million come into the province in federal transfers alone, plus our sales tax, our land tax, our income tax. We're resource-based. We don't participate in the spending fest of the provincial government. Our best estimate is that the province spends all in, including the $4 million at the hospital, about $12 million in the hospital. And I think it's about time that we send the message out that the people in this area don't live off Charlottetown. Charlottetown lives off of us. So, despite the massive growth in spending in health, we have seen continued cuts to health care only in rural areas. And it didn't start with this administration. I fought against the Binns government when they took local health boards out of the area. The Canadian Medical Association notes that seniors and lower income people require higher health services. In a huge study in the U.S. on rural hospital closures, 75% of the mayors in those communities said their communities suffered economic decline, more lower income people, and as a result, greater health care needs. The Canadian Medical Association also recognizes the importance of public consultation, and they are currently engaged in a massive Canada-wide consultation. Ontario has elected health boards because the minister said, I quote, "We value the input of the public." Yet, East Prince Edward Island, and my understanding is the Western Tip also, have no representative on the health board because the closest member is in Montague, and Charlottetown continues to think that Souris and Montague are the same place. So we will be at the legislature on the 18th to grant our voice. We talked to Alberton about this in our island-wide coalition. We want local administration, local health boards, and local ER, as promised by Premier Giz. I was speaking to Mr. Sheridan on the way in this evening, and he said that Premier Giz did not promise the restoration of ER in Souris, and I said, was I the only person that heard that? Did anybody else hear that promise? Minister Sheridan, I did not make that up. Check with your boss. Noting that the above-mentioned reasons are essential and legitimate issues needing address, I realize that the number one reason for public interest in this issue is the desire to have good health care, and that there is recognition, particularly in this community, that right now the healthcare system is dangerous, and this proposal will make it more dangerous to our well-being and our lives. The ambulance service is unsafe. The Auditor General recognizes it's substandard. There's no consideration for the weather system in Eastern PEI and Western PEI, and that's a scientifically proven fact that we have a different weather system than Central PEI. They can have a heavy snowfall while we're having a storm. There are operational issues at the Queen E, like one of the highest readmission rates in the country. I think I was not the only person that didn't recognize the 1 to 2 hour wait at the emergency room. And there's great concern that in this plan, there's no expansion of Montague or Alberton or anyone else to handle the extra capacity. So what we're saying is enough. We stand up for our own health and our own life, and we demand sense, we demand safety, we demand decency. We oppose the addiction to debt-fueled centralization. We oppose the disrespect for democratic process, and we oppose the dismantling of Medicare for the good of the people as a business model for the privileged that creates a system that's dangerous for the rural people of PEI. And my question to the minister is, will you cease this proposal immediately and agree to engage with island-wide hospital access and the people of PEI to figure out a healthcare system that is both effective and economically sustainable?
Well, thank you very much, Alan. You got the crowd going. Anyways, thank you very much, Alan. Certainly, I would enjoy having more conversations with you in respect to the challenges facing the province here in healthcare. And I just there was a lot of information that was shared, and certainly in lieu of time, I'd certainly would encourage a conversation between us and a group to continue that dialogue. And certainly this model really, if you look at it and if you look at the data that was presented here tonight, is really what the objective is, to fully deploy the facility here in Surrey. And we know that the occupancy on any given day in the facility is at approximately 75%, which means that there is patients that could be from this area, that could have family members on stretchers in the Charlottetown hallways. And I will answer the question. That need access, and access to an acute care bed for a service that is provided particularly at the PCH and the QEH. So certainly the objective here is to make sure that we don't have empty beds, that we have a facility that is functioning to its full capacity every day, 365 days of the year. The challenge that's facing me right now as the minister of this province, and I look at healthcare across the province, is that I have to look at equity. And you referred to the number $22 million spent for community hospitals, which is right, but the total health care spent for community hospitals and primary health care is about $82 million. So that includes mental health supports, that's public health nursing, that's mental health and addictions, that's not including the physician salaries, but that's not also including the services that are also covered off island and part of that $50 million. And I'm not going to sit here and spit out numbers all night, because that's certainly not what you want to hear. You want to ask questions. But the reality of the situation is right now, as we indicated, and I've experienced, the system is not working right now here in the province. It's unacceptable that we have seniors and children in stretchers in hospitals, in our main referral hospitals, while we have vacant beds in smaller facilities. We need to use our community hospitals to their full potential and make sure that we're using those resources to make sure that we're protecting the main recruit services that all of you and some of your family members may require at some point in time. So the system's not working right now. Status quo right now is not an option for me as minister. So thank you. The question is if I would stop. Right now, I have the challenge, realizing that I've got individuals on stretchers in Charlottetown. I can't stop the process. I can't. My objective right now is to use all our assets. There's no beds been closed. There's no hospitals been closed. We've increased our spending in home care spending, primary health care. We are investing in health care, and we're seeing the growth in budgets in the province. So that's my response, and I look forward to more questions.
I ask that if you have questions or comments, if you have questions or comments, please come to the microphone here, and I think Gerard will be the first.
Yeah.
Good evening, everyone. Is that okay for volume? Okay, my name is Gerard Holland. I'm the former owner of Kings County EMS Ambulance Service. I have friends on both sides of this equation this evening, and I was asked to be involved in this process 2 weeks ago. I didn't have much notice. I spoke at St. Mary's Hall for a few minutes. Couldn't provide shed very much light on the situation. After that meeting, I did some research. So I'm here this evening to provide two things basically: some stats, some stats, simple stats, and also, in my opinion, what I feel is fair and just to the people of this community. Back in 2006, as you may remember, we had the ambulance service up here. At that very time, we were told in this community that, I'm sorry, but your emergency room department has to close because we don't have doctor coverage. And I think you people understood that. As the result of that, things were done, and Souris was bumped up in their EMS service. Traditionally, we had one truck in Souris 24/7. The bump up in that service was to 2 trucks in this area 24/7. And that lasted for 3 months. And at the end of those 3 months, as you all probably know, but I was taken out of the equation, so I may speak. I continued as an employee of Island EMS, and I think Island EMS is a good company. I really do. But you need to know some things about this stuff tonight, folks. The stats that I had from Kings County EMS in the Souris area responding to emergency calls were 13 minutes on average responding to emergency calls. And that's just black and white, folks. It's just black and white. Right now, we're looking at, in regards to emergency calls, the numbers that I've gotten off of the stats from Island EMS is that you're looking at double that time. You're looking in the vicinity of 24 to 27 minutes. It's double. It's double. Colin says it's triple. So, and I looked at the stats across the island too, and I can revert back to my statistics because I was involved in the Souris and Montague end of things, obviously, but I don't have the statistics for what the numbers were for the EMS services back in the other companies on the island. But a lot across the board, I think what we're looking at here is, what we're looking at here is Souris is basically doubled in their emergency response times. Montague is very close to being doubled. Alberton now has emergency response times of 20 to 22 minutes. O'Leary has emergency response times at 24 to 24 minutes. I base that off of this document, which is an article from Island EMS dated September 19th, 2012. And I base that information off of this document, which is the statistics that represent this article. These are the response times, folks. As Jeff mentioned, a lot of ambulance service response times are based on percentiles. And I really do believe, I'm not trying to get anybody in trouble here, but I really do believe that the stats that we've seen up there this evening are very misleading. Yeah. What I think they've done is I think they've basically thrown all the numbers in the hat, and they're saying that emergency response times are less than 30 minutes 90% of the time. I have no reason not to believe that. I believe that's probably true. But it's misleading to put Souris up there and say that they're having 90%. You don't run 25, 30-minute response times on average and get to your less than 30 minutes 90% of the time. That's just physically impossible. And like I say, the stats that I've got here, if somebody wants to take me on in these stats, you better bring a big stick. Because I'm just trying to provide the information, but I'm sorry, but you can't run response times of averages of 25 to 30 minutes. And then you're saying that you're doing 30 or 90% of the calls are 30 minutes or less. You just get a mathematician. Where's Shane McClure? It just doesn't work that way. At any rate, I do believe that the island as a whole are probably being run at 30 minutes or less for 90% of the time. I do not believe for 1 minute that Surrey is being taken care of 30 minutes or less 90% of the time. I just don't believe that. So what's really happening, I think, on this island right now is that I think Island EMS doesn't have the resources to provide all the service that they should be providing. And when that happens, what you do is you play the numbers. Sorry, Susan. What you do whenever that happens, you play the numbers. I mean, think about it. You're going to try and, if you have to cheat a few places, you cheat in the places where you're going to get burnt the least. And I'm sorry, Minister, but that's not fair to these people. In essence, what you're doing here, Minister, is you're playing Russian roulette with these people's lives. Sorry. As a result of what happened a couple of weeks ago and this coming to light, I've gone on a little tour of our fire departments. And they're here tonight. So it's no secret to you folks, but what our fire departments do is they do medical first response, they do motor vehicle extractions and services, and they are the people that run into burning buildings while the rest of us are running out of burning buildings. They have credibility. And now we're asking them to save our hospital and our EMS service. Volunteer, right. I'm going to read a letter. I have this signed off by, I'll get back to that. It's addressed to Premier Giz. The letter goes in response to the recently announced hospital bed changes to Surrey Hospital, Community Hospital, Stewart Memorial Hospital, made by the Honourable Minister of Health, Doug Curry. As Rural Fire Department medical first responders, we request the following. Number one, the need for extended care and long-term care beds in Prince Edward Island be recognized so as to not be at the expense of the current acute care beds in the communities of Alberton, Tyne Valley, O'Leary, Montague, and Surrey. Number two, the EMS services being provided by Island EMS in the rural communities of Prince Edward Island be restored to an acceptable standard of care response time consistent with the previous EMS service response times provided in those communities by Rooney's Ambulance Service, Alberton, West Prince Ambulance Service, O'Leary, and Kings County EMS, Montague and Surrey. Furthermore, we in no way want the response times improved in our communities to be at the expense of other PEI communities such as Charlottetown and Summerside. We hope that your administration would respect the requests as outlined in this letter. Failure to do so may result in rural fire departments re-examining their role they play as medical first responders in PEI's EMS system and or other regressive action. Should you have any questions or comments in regards to this letter, please contact myself. We look forward to your response in a timely manner. Not interested in this taking a year to get back to us like we did with dialysis. Minister, that's signed off by Cardigan Fire Department. They're here this evening, guys. Central Kings Fire Department, guys. Eastern Kings Fire Department. Morel Fire Department. Surrey Fire Department. And St. Peter's Fire Department. Folks, to use a wartime quote, in my opinion, with these fire department guys, this is the hill they are going to die on. Doing the same thing in the Montague area. We're trying to feed in the Montague area so that we can get the fire departments in that area to come support the same process that, like this meeting, it's going to happen in Montague in a couple of weeks' time. And last night, I went up to West Prince Mutual Aid Fire Department last night, up in Lennox Island. And as a result of that meeting, I have another letter here. It's addressed to myself. The letter says, I am sending you this letter to present to you a motion passed at the West Prince Mutual Aid meeting on April 9th, 2013. West Prince Mutual Aid, consisting of Miscush, Wellington, Tyne Valley, Lennox Island, West Prince, Alberton, O'Leary, Tignish, and Minimagash. All our 9 fire departments have trained emergency responders, provide first responder service to the fire districts. The motion they carried is the same motion that I said. They used my quote from my letter. So we're not going to go through all of that again, but basically saying that the response times be restored to an acceptable standard of care response time consistent with the previous operators in their respective communities. Furthermore, we in no way want to have the response times to be jeopardize other Prince Edward Island communities like Charlottetown and Summerside. Their final note is that we look forward to an improved response times. That is signed by Desmond Arsenault, Chair of West Prince Mutual Aid. I don't know, is Gary Dingwall here tonight? Because, as you folks know, Gary Dingwall is a man in our community that spent over half of his life on call for this community. And I'm sorry, but taking from the quote that I have, that I presented here earlier, that Eileen Massa said, there aren't enough calls to justify additional ambulances in Surrey. Can you imagine saying that to Gary Dingwall? Can you imagine? For all he's ever done for this community his whole life, and I can't imagine saying it to that man where you're going to say, I'm sorry, but it doesn't justify having another truck up here. At any rate, I want to talk for just a second from a paramedic's point of view on our hospital. For heaven's sakes, folks, our hospital is one of 5 hospitals. Our hospital requires less than 1% of the provincial budget allotted to health care. It is the best bang for your buck you will ever get in health care. I'm going to provide an example of the way I see life. A lot of people talk about how our small hospitals, some people talk about how our small hospitals are failing us. They're not failing us. They're thriving. They're doing whatever needs to be done that can't be done by everybody else. I'll give you an example. An ambulance in this community, and probably not so much in this community now because all the ambulances go to Charlottetown, but back in the day, if you had an emergency room department in Surrey and you had an ambulance call, if the ambulance bypassed Surrey Hospital, everybody at the coffee shop would be saying, oh boy, that hospital, that's just whatever, they bypass. That's the talk in the coffee shop. Well, for every one person, I might need an ambulance myself tonight here. For every one person that an ambulance, in my opinion, every one person that bypasses an emergency department, a rural emergency department, there are about 100 people that go into that emergency department and get the services they need. And they're getting those services by people that are from doctors, nurses, lab techs, the whole kit and caboodle. And they're getting well served, folks. So do not let your hospital go. Minister Curry, and I realize that you've inherited quite a bag of items here. I realize that. I mean, it wasn't this administration that got us into this problem 7 years ago with closing an emergency department. And I respect that you have a lot of tough tasks ahead of you in the run of a day, in the run of a year, and in these communities. But I'm sorry, Minister, but you have to stop talking to the backroom boys in Charlottetown about how to fix rural health care and PEI. Talk to the x-ray techs, talk to the ward clerks, the doctors, the nurses, and the medics. Talk to them all. And if you ask me, if this community can help you out with your long-term care bed problem, I'm pretty sure they will. But I'm pretty darn sure it's not going to be at the expense of the acute care beds. And again, Minister, and you inherited this mess to some degree, but if you ask the question, why don't these people trust you? Well, they had their emergency room department closed. They dropped the ball on your EMS service up here, and they tried taking away your dialysis services. Why would they trust you? And a reminder, I mean, this is the community that took on the New Brunswick Hair and Fishing Industry, which had the support of the federal government. And they beat them. And as you know, Minister, they took on dialysis, and they won that fight. And we're asking our firefighters to save our hospitals and save our EMS system. And that's where this is going to go, folks. It's going to be a fight, but I think the boys are up for it. I want to leave, 2 weeks ago we heard some quotes, and I want to leave you with a quote. This quote is from a famous doctor. If the bureaucrats would stop sticking their noses in where it doesn't belong and leave health care to the professionals, we'd all be a hell of a lot better off. That doctor's name is Steve O'Brien.
Gerard, thank you very much for your information. I'm sure you'll be joining Mr. McPhee when he comes to meet with me in Charlottetown, or me coming here.
When you come to Souris.
Exactly. Anyways, I just want to say a couple things in respect to ground ambulance. Basically, yes, Mr. Holland was right in respect to, I wasn't the minister, I wasn't in politics in 2006 when the 10-year agreement was signed. But just with that being said, certainly I will throw, and I've done this numerous times, and I know the leader of the opposition is here, I will throw a bouquet. I do see and have the opportunity to work with Island EMS and see tremendous upsides. With that being said, I haven't renewed their 10-year contract, which was up this year. And yes, the Auditor General has made a number of recommendations on reviewing. I've met with the ownership of Island EMS and Medivive at Halifax and said, until we get a clearer picture of what the issues and some of the challenges are, we'll not be signing any extensions into the contract. But with that being said, I will compliment the former administration, and the leader of the opposition is here tonight. I do believe that there is upsides. The world of paramedicine is different today than it was 10 years ago. I'm not a paramedic, but from what I've witnessed in my time as Minister of Health and what I'm seeing, I think that we are very fortunate to have highly trained professionals. Is there opportunities to continue to improve response times and make improvements? I didn't say we were batting 1,000, but certainly as the minister, I'm willing to continue to look at investments, what we need to do to respect the challenges in respect to response times. So with that being said, we'll continue to have more conversations. So I will leave any more specifics to Mr. Waring from Island EMS as well. So
I just want to leave a final thought on Island EMS, Minister. Island EMS is a good company. They have good medics. They have good managers. They work very hard in the system. I just don't feel they're getting the proper resources to provide proper coverage to all islanders.
Thanks a lot, Gerard. Gerard, appreciate your comments. I've been working in Surrey and Montague with Gerard for many, many years. I worked out here for 13 years. And I can tell you, and unequivocally, that you have some of the best paramedics in Canada. I personally have worked in Vancouver, Calgary, over the world. I've worked with paramedics all across this country and in Europe and other places. They are second to none. Their training is second to none. They do an excellent job. The stats that he had mentioned, and Jordan, I can't comment on your stats because I'm not familiar with them. We keep our stats with the same system that every other EMS system, high-efficiency EMS system uses across North America. They're based on a survey and a study that was done in 1977. It was a study based on how to correctly gather stats and how they affect response time. So it's the same standard they use in Toronto, in Ottawa, in Vancouver, in Texas. We use the same system. We gather our stats. All our stats are time-stamped from the time you phone until the time they arrive on scene. I'm going to give you, we have made improvements. In Surrey in the year 2011, our urgent was at 2459. Last year we got it down to 2359 by maneuvering our stuff around. Now you got to remember that's not Surrey proper, that's the whole area around it. So we've made improvements in every jurisdiction across across the province. With these new assets that Health PEI is bringing into it, we are very confident that we will drop that again. I want you to remember that typically in Calgary, if you called for an ambulance, their shoot time to door is 8:59, and we're pretty darn close to that in some of our areas. And they have a lot more resources, a lot more money fiscally. It's a big province. So that's all I have to say. I will say that the stats in Surrey over the last 5 years, the call volume has dropped, and it's not a fictional thing. It has dropped to this point where we have 331 emergency calls a year coming out of Surrey area. We have one ambulance here, and like I said before, our deployment is dynamic. It is changing depending on how many trucks we have in the system, and we've added trucks over the last 4 years, probably 3 or 4 trucks as needed. Anyways, thank you very much.
My name is Susan Burt, and I don't believe in talking to people with my back to them, especially my neighbors and friends and community members, so I'm going up there. Find a place for all my little goodies here. I want to start with a couple of... can't hear me? By God, my husband never says that. Thank God. I have a few comments, and then I have a couple of questions for Mr. Curry. And the only answer I want is yes or no. That's it. I don't want reams of paper or whatever. I want a yes or a no. First of all, just as a quick note on the ambulance issue, I guess it was about a year ago, some community members came to me and asked me if I'd do a little bit of research on ambulance services. And I'm not an expert in ambulances, and I'm not a paramedic. I'm a retired bureaucrat. And anyway, I did a little bit of looking, and I started on Health PEI's own website. And lo and behold, there was our ambulance contract. And anybody that knows me knows I read. And I read it. And there also was New Brunswick's and Nova Scotia's. Same company, same contract with government, with one exception. Both those provinces had response times indicated and performance measures indicated in their contracts. And do you know what PEI says? best efforts. So I'll get to you when I get you, and it was my best effort, and there's not a bloody thing you can do about it. So when you go to renew it, you might want to read that particular clause. Now, that being said, I promise you that I did not get in cahoots with Alan McPhee, but also anybody that knows me knows I have a very long memory. And I remember things that other people perhaps forget. And yes, I too heard the promise of Premier Giz. Not only did I hear it, but I have a shiny red document here. And I will be very pleased to provide that document to the provincial treasurer. And if he'd like to table it in the legislature, he can do so. And if not, he can read through it. But I'm going to read a little bit to you folks right here. Liberals are committed to putting the health care of rural islanders first with the following initiatives. Number 1, securing adequate physician and other health professional coverage to support the effective operation of all our community hospitals in meeting the medical needs of their residents. There's only 2 or 3 more here. Developing and implementing a $1.5 million rural doctor recruitment and retention program, and I recognize that they have done their best perhaps, that increases the complement of rural physicians to support all our community hospitals. Developing a rural nurse practitioner model of healthcare delivery, which is where I personally think they should have gone in the beginning. That's my opinion. And number 6, developing a 10-year plan for rural healthcare with meaningful community input. This is not meaningful community input. A Liberal government will put islanders first by eliminating fees for emergency ambulance services. If you want to know why your calls drop, it's because most of the people here can't afford the $150. Now, there's a few other little goodies in here, but I will give this to Minister Curry, and he can pass it on. So now we head to the issue at hand tonight. And as I said, I'm a retired bureaucrat. I took my job and my responsibilities seriously. And as I said to somebody last night in a meeting, I spent 20 years in healthcare, and I never had a deficit. Never in 20 years. And it wasn't because of me personally. It was because I started every year with my staff by saying, we have 2 choices, 0 and plus. And that's it. And when we start going the other way, we either have to short shift some shifts, we have to do something different. And I would suggest that maybe Health PEI needs just a little bit of that common sense. Now, here's my yes or no question, Minister Curry. Other than the briefing that you would have received from the Corpus Sanchez group and your senior staff, have you personally ever read the Corpus Sanchez report from beginning to end? You have. Fine. I'm glad to hear it. This is my very well-worn copy. I have been tracking. I spent 20 years, and I'm still interested, and I spent 20 years fighting for this community. So may I ask you this question? How many recommendations for increases in service are in this report? Increases in service? No. Because you'll take too long. Just give me a ballpark. Do you know? If you don't know, I understand. In 2009, and I read it then. I've been following you, but I haven't read it through since. How many recommendations? 10, 15, 20, 100? Okay. I'll help you. Because nowhere in the report does it itemize them. What it does is it makes the reader go through and find them. Here's the list in my handwriting from 2009. There are 37 enhancements called for in that report, all costing new money. New money. 5 are costed. The cost of those 5 are between $10.8 and $20.5 million in 2008 dollars. New dollars. 32 are not costed. I would submit to you that the province of PEI has been sold a bill of goods, and if you had the entire provincial budget, there's no damn way you could implement that. And the presumption that's made in the Corpus Sanchez report is that these enhancements would be made before there was any changes in acute care services or any bed services. Now, I really am trying to understand what the anticipated change is, and I don't consider myself a stupid person, so I kind of think I got a handle on it. But then I watched Dr. Wedge's presentation with great interest, and I thought, oh, something funny about that. Your stats there, one of them that you were showing that any one given day, we have 41 people in acute care beds at the QEH, right? We have 29 bed blockers, for lack of better term. I'm going to get a T-shirt. I'm not a bed blocker. But anyway, didn't have time to get it for tonight. I'll have it for the next meeting. But anyway, so 29 people are awaiting placement, correct? No. Alternate site. They're not awaiting placement for long-term care. They should be in an alternate site, which is what you want to use your ALCs for. And that's not Atlantic Lottery Corporation. I understand that. Okay. So my question, or I guess my comment would be, if we've had a hospital out here that had a 75% occupancy rate, why in hell didn't you transfer some out? For me, I'm getting to the end here, but I would also note that of those 29 people, surely to God, not all 29 are from the east or the western end of the island. Some are from Stratford or Charlottetown or somewhere, right? So my question, I need a little bit of water here. Yeah. Anybody else got anything else? I'm coming with you. So my question is this. If I, as a resident of Souris, have a medical issue, and I wind up at the Queen Elizabeth Hospital, and I recover sufficiently that I no longer need an acute care bed, you are going to transfer me to Souris Hospital to finish recuperating. If I am a resident of Charlottetown or Stratford, and I recuperate where I no longer require acute care, am I coming to Souris or Montague? Then why did you say your Prince County Hospital and the Queen Elizabeth Hospital are also going to have alternative level of care beds? I know they're not all coming. But you had 29 in any given day, and you had a 75% occupancy out here. They're not all Eastern Kings residents. 3 or 4 will come. But people from Charlottetown are coming out here. I will believe it when I see it. My husband was a hog farmer, and as we used to say, when pigs fly, right? And also, I would assume that the same would apply for Summerside, for Prince County Hospital. So it has to happen that way, because if not, what your goal is to make access to acute care beds. And you need to be doing that based on need and not residency. If there's a separate tiered system for Charlottetown and Summerside, look out. I don't begrudge them what they have. Good luck to them and all the rest. But this is just not acceptable. I really think, first of all, the Corpus Sanchez report, in my view, is flawed. I think you were sold a pig in a poke. As I said before, I don't think there's enough money in the province of PEI to implement that report. You've said you've read it. I would encourage you to reread it. Get somebody like Doug Clow to do some costing, and you will very soon come to the conclusion that there's no damn way you can't afford it. And then you have to have a conversation with communities like this to look at an alternate service delivery method. Now, this is my final comment. I'm just getting warmed up here now. And in the way of full disclosure, I want to let you know, in particular, that I'm not on Twitter, I'm not on Facebook, and I don't want to be tomorrow morning. I will further advise that in a moment of weakness a number of years ago, I once ran for the nomination of your party in District 1. And thank God I didn't get it, because I would have had to cross the floor about 5.5 years ago. And again, because we have to know everyone's political affiliation. My father was a Liberal, never knew what my mother was, didn't get to know her that well before she passed away. But anyway, in the interest of full disclosure, I will also add, I have held a PC membership card in the past, and last night I attended the organizational meeting for the NDPs in District 1. And as a final comment, so that we can put McCarthyism to bed, and I'm sure there's a few people here old enough to remember that, I am not now, nor have I ever been, a member of the Communist Party.
Thank you, Susan.
Well, ladies and gentlemen, I feel like I'm at the wedding in Cana. The only difference is we had the good wine already, and now you're stuck with me. Seriously, I have a couple of very quick questions, and unfortunately, I'll probably preface them with a few comments, Minister. My first comment is this. By the way, I guess I didn't introduce myself. I'm Dave McDonald. I pinch hit as the mayor of this town once in a while when I'm not fighting health issues. Mr. Minister, my first question to you is quite simple. We wouldn't be having this meeting here tonight had you saw fit to simply come here and tell us what you were going to do instead of standing up in front of a microphone in Charlottetown and telling the rest of the province what you were going to do to us. Having said that, someone referred here earlier to the cost of these meetings and the fact that a consultant firm has been hired. That seems to be the government way to do things. I've had a bit of experience in, running some of these meetings, Mr. Minister. I would have volunteered to do it for $50. Having said that, I have one quick comment, and that's this. Your health budget seems to me to be extremely bureaucracy heavy. And I was wondering whether or not you were going to do anything about it. For the past 30-some years, we have a lady in this school who's a secretary. She could do more work in one day than one floor could down on Garfield Street. So basically my two questions are this, Mr. Minister. Number one, are you going to stop making these announcements from on high, and are you going to come out here and talk to us one-to-one so we don't have to rush out to these meetings? And second of all, are you going to get somebody with a sharp pencil to get a hold of your expenses, especially in your bulging bureaucracy on Garfield Street? Thank you.
Sorry, my voice is fading here, but I'm not sure exactly what's meant by bureaucracy, but there are different ways of measuring how much. Well, but there are different ways to measure healthcare administration costs, and there are two reports that are done nationally by different hospitals and different health authorities. So if you look at it from the point of view of the number of people that are in the corporate system or finance system, and you add that all up, that's one way to do the percentage. But the other way to do it is through CIHI, and PEI actually has amongst the lowest healthcare administrative costs in the country. So we'll try and put those explanations up on the website for people as well, so they can read sort of those two different ways of doing it. One was the CD Howe one that was in the paper the other day. So.
Hi, my name is Mona O'Shea, and I am the president of the PEI Nurses Union. I'm not from this community, and I'm here tonight to represent the membership, which are the RNs in the community and the nurse practitioners. Now, Minister Curry, Minister Curry and Dr. Wedge, this is the third time that I've heard your presentation, and I must commend you on the consistency of it. However, it does lack a concrete plan for the implementation of this healthcare plan that you're doing here, and also the time frame around when you want to implement this. So I welcome an invitation to engage in conversation with you in the process of this plan. And the other comment I'd like to make is that in the past recent months, Model of Care has been implemented at the Souris Hospital, and there were a number of registered nurse positions deleted at the hospital, and we also saw some registered nurses surplused at the hospital. Now, while the registered nurses here in this community are fearful of the unknowing and where they're going to be working tomorrow, more importantly, they're concerned about the quality care and the service of the patients, and that it does not suffer. So we need to keep focus on that. Thank you.
Good evening, everybody. Good evening, Minister. Good evening, CEO. My name is Ron Henbest. I'm one of the two family doctors in Surrey. And, I thought just for fun it might be fun to have a doctor say something at some of these meetings about healthcare. Partly I just wanted to greet you, so hello everybody. I wanted to say a couple of things though. I was wondering, Mr. Minister, if my heart kind of went out to you as you described the situation about the 94-year-old woman lying on a stretcher at Q8 Emergency Department. And the first thought that crossed my mind is if she was a 94-year-old woman from Surrey, maybe she didn't have to go to QEH and lie on a bed in the emergency. I really think it's a rough ride. We have a lot of people every day from Surrey, and maybe some of you have had the experience where you actually wait and come in to see your family doctor, either Dr. Barrow or myself, or perhaps one of the locums, with your illness and get admitted directly to the hospital. In which case, you're upstairs in a few minutes. We start treatment. You're in a place that you know, with the doctor that you know, amongst the nurses that you know, with the wonderful food that we have at Surrey Hospital that you know. It just seems to me to be a much more humane experience, isn't it? I had heard too the 72% occupancy rate. I sort of smiled at statistics. It kind of reminded me of the statistics they have in, I can't tell, is it better when I'm that close or is it better when okay. The statistics they do when you do drug trials. We'll have a drug trial where let's say that twice as many people got better with this drug than with this drug. Then you find out in the one group there was one patient and in the other group there were two patients, so twice as many. So the 72% sounds like a bigger deal, but I did hear Richard say, well, actually, it's really only 4 beds you're talking about. that are empty. If it's 25% of the beds are empty and we have 17 beds, you're talking about a total of 4 beds. I don't know how many of you run and own hotels, but even when you have a maximum occupancy rate, it's never 100%. You can't actually have a patient enter the bed as the other one's sliding out. Well, that wasn't really worth a clap. I just thought. So we're really talking about these 3 or 4 beds, but as our last speaker, I thought that lady would be, sounds like she'd be really wonderful. I wish she was running the manor now, but I understand that she used to. Anyway, what I was thinking on that was that, well, the CEO was challenged, why didn't you put those people here? And I know from our senior nursing staff that have to do with this that they often welcome them. QEH will phone and say, we've got, say, 6 people we'd like to transfer. And we'll say, okay, we'll take them. And then, of course, they don't want to come because they're not from here, right? They're from Charlottetown, or they're from Alberton. In fact, I had an experience like that myself where one of the physicians phoned and asked me if I'd take a patient, and I'd said yes. I said, but have you asked the patient about it? They said no. Edmund had told them to free up the bed, so they were calling me to free up the bed. And I said, well, I'd be happy to take them, but I suggest you at least consult with the patient and their family to see if they're willing to come. And they weren't, and that's quite a common experience. I think people like to be cared for close to home. Okay? I spent most of my practice life, I'm from Edmonton, Alberta originally, and I'm really glad about the service that Alberta provides to people in PEI for employment. Small contribution we make. I have personally freed up one spot in Alberta by coming here. Anyway, I spent most of the last 35 years in rural Africa. And they also have trouble with health care, and they're even poorer than Prince Edward Island, if you can believe it. And their idea for health care, their motto, their goal, is to have primary health care, for which they mean acute services. And what they mean by acute services isn't near as complicated as some of this. It means if you're sick and you need help now, this is where you go. That's acute to them. And they want it to be within walking distance of every household. Walking distance. That's because there's no cars in most of the places that I've worked. And that's their commitment. Somebody gets sick, they can walk or go by donkey cart to the closest clinic. And there's somebody on call that will see them, do what they can there, and then make whatever necessary arrangements. So I think that that's what people want. They want care that's close to home. And I think that it's more cost effective. Of course, it's cheaper if it's closer. It's quicker if it's closer, right? And often it's a completely different environment. The final thing I thought I'd just comment has to do with sort of scale of size. When I got a license to practice in Prince Edward Island, it's different for each province. You can have a license in Alberta, you can have one in British Columbia, you can have one in Ontario, you can have one in the Northwest Territories, but you need to get a separate one for Prince Edward Island. When I got a license for Prince Edward Island, they suggested that I speak to the Department of Health about where doctors were most needed, and I did, and they gave me a free trip to Souris. And I've just heard how much they spend on that. I could have held out for a little bit more. In fact, when I heard about the $10,000 relocation cost, I just hired 2 guys in a van, and it cost me $720 because I'd been assured I would get that refunded. But when we sent in the receipt, they said no, because I was local, they wouldn't cover the cost. So I might try again with that $720. Anyway, I came out to Souris, and I wasn't sure if I wanted to work again. I thought maybe I was sort of going to be retired and just enjoy retirement here. And I had a tour of the hospital, and in fact, I did a bit of a ward round with our charge nurse. And I was so moved by the hospital situation. Patients that were genuinely happy and felt cared for there. The nursing staff that really cared for the people there. My heart really went out to them. I thought, this is really a wonderful hospital you've got. I have worked in many hospitals in many places. I would easily put Surrey as the hospital that I would most like to be admitted to if I became ill. So I'd like the minister to seriously consider that the best thing for the 94-year-old women laying on stretchers in hospitals is to be seen closest to their own homes, wherever that is in Prince Edward Island. That any of the rural hospitals can provide as good a care as laying on a stretcher in an emergency department. I'm kind of looking forward to more of these meetings, too. Thanks very much.
Just before I ask you there's quite a lineup of people with questions and comments behind. I can see. And so I think the lady with the red, that's wearing red, is at the end of the line right now. And I'm looking at my watch. We're going to be finished at 9:15 as promised. So I'm going to ask that.
Steve, ask for an extension from the minister. Ask for an extension from the minister.
You guys okay to go on?
The minister indicates he'll stay as long as necessary. Mr. Minister, head table guest here, I guess, and you folks here tonight. You can't hear me? Am I too tall for this, am I? Is that better? I want to tell you folks that approximately a year ago today, we met my group, and I should say who I'm with. I'm with the Northeast PEI Community Alliance. Immediately following the dialysis situation last year, we requested a meeting on May 7th with the minister. We were granted that meeting on June 28th. A group of us went to that meeting. We felt we had a very good meeting and we had a very good dialogue. And we were told that things were going to change, that from now on, Health PEI has realized that they're not conferring with the population of PEI, they're not conferring with people, and that was going to change, and it was going to change before anything major happened. 4 months later, we wrote a letter and said, when do you plan to start? Didn't receive an answer to that letter. When this crisis hit, we again wrote the minister, and in that letter I read at the previous meeting, and we asked to meet with the minister. That was granted, and in fact we met with the minister this morning. Anyway, the consultation promised last meeting didn't happen. We asked specific questions today, and I don't think we got one specific answer to any question that we asked. There was no evidence, this is an hour and 3/4 this morning, there was no evidence given at that meeting that showed me how the proposed changes were going to in any way help Souris PEI Hospital or the Queen E Hospital. If you take our acute care patients out of Souris, out of O'Leary, out of every other small hospital, and you put them into the Queen E or the Prince County Hospital, which do not have enough acute care beds now, I think you just made the problem worse. And I firmly believe that if you think that you're going to take Charlottetown residents and Hunter River residents and other people and ask them to come to Souris Hospital or O'Leary Hospital, by ambulance I guess, to finish their stay in hospital, I think you're going to have quite an uproar in your hands, and this little revolution you have going on in rural PEI is going to hit the main centers. Not to mention the fact that to do all this shifting back and forth, we've added apparently one vehicle now to move people from building to building. If this policy starts, how many more are we going to need to move people? It's the ambulance service, if they're used, it's going to increase the crisis there. I don't think this is going to work. I can't see. Anyway, to repeat what I said, there was nothing that our group got from that meeting this morning. It was an hour and 3/4 that in any way gave us any assurance that there was going to be any improvements to healthcare and PEI. I think the idea may be to marginalize rural hospitals, and maybe that in the future, once they're marginalized far enough, we'll be able to find an excuse to maybe further degrade the service that's provided there and centralize things more to PEI, central PEI. It appears that Health PEI has no plan. There's no plan that's presented to the public. I was told today that there's a strategic plan that's been worked on with public consultation over the last year. I said, gee, really? I guess you forgot to invite us, did you? So apparently that plan is on the minister's desk now for his approval. And I suggested today at that meeting that it might be kind of a milk and cookies type plan that made you feel good when you read it, but there's no specifics in it. And I was told by Dr. Wedge that these things are ongoing. You can only deal with economic issues as things change. The health industry is changing very, very fast, and you have to respond to those changes. And I would say to you, if you tried to run a business the size of Health PEI with that attitude, you would have a very dysfunctional, and you would probably be in receivership in a very short time. I think long-range planning is critical, and I think you have to have that well in advance to be successful. Anyway, for me, the gloves are off on this issue, and people of the town know that I try to be democratic and that I try to settle things without getting aggressive. I don't think there's any point in that, but it's not working. It's not working. You're not listening. There's a very elite few deciding what's happening in PEI healthcare. This latest change, apparently the surgeons and doctors were not consulted. The nurses were not consulted. I don't know who was consulted. Anyway, following the last meeting at St. Mary's Hall to discuss the community action, the group that organized that meeting received a strong endorsement from the residents in attendance. They have subsequently become formally organized as Island-wide Hospital Access Souris, and they form part of the total island-wide group. Due to the fact that this group has stepped forward and has obtained strong public support to lobby for change in healthcare delivery in the area, our group, NECA, will be deferring any active role in the current issue. We will endorse and we will support Island-wide Hospital Access Group as they continue to work to retain essential health care for residents of northeastern PEI and all rural islanders. And I know, Minister Curry, you say this is not a political issue, but I'm going to give you some political advice very quickly. I think if you persist with this current tact in medical service in PEI, I can almost guarantee that you'll need to look for another job after the next election. And I will give you credit. I will give you credit for your speaking ability and your ability to be able to sort of talk a big story. So maybe if you're out of politics, maybe the sham wow guy will need to be replaced on TV or something. I probably shouldn't have said that, but anyway, Mr. Minister, I urge you to put the brakes on this whole situation. Islanders and people need to be consulted. They need to be part of the decisions that are made, and I see exactly the opposite has been happening for the last number of years on PEI. So please consider holding things up, developing a plan, putting that plan on the table, making all islanders aware of what's in that plan before you proceed.
Mr. Minister, Dr. Wedge, Mr. Mayor. I'm Dr. Rosemary Henderson. I'm the medical director of the Queen Elizabeth Hospital. And I'll try and be brief because I know this is your opportunity to speak, not mine. But I wanted to express our appreciation, my appreciation specifically, and the Queen Elizabeth Hospital's appreciation for the care that the Surrey Hospital provides to the patients that we do transfer up. You've got a lovely hospital. I've visited it in the past. You've got great staff, and you provide very good care. And yes, the reputation of your food is certainly something we're aware of. And we've been increasingly transferring patients up to your hospital over, I'm guessing, the last couple of years or so. And yeah, some of them are patients from the Surrey area for sure. And some of them are definitely not from the Surrey area. And we find, and I may stand to be corrected by Dr. Henbest, but we find that, I think, patients accept the transfer up to Surrey, who are not from your area, a bit better when we have prepared them, when the doctors have told them, yes, part of your stay, part of your convalescence may be in Surrey, because most of the patients we send up are convalescent or subacute, occasionally acute patients that we admit right from the emergency room in our hospital, but who just they're not sick enough to require the really specialized services at the QEH. We do find that there is resistance from patients when it's just sprung on them, and unfortunately, I'm one of the people who sometimes has to talk to patients and say, I'm sorry, I know you don't want to go, but we simply have to move you so that we can bring up someone who's sicker from the emergency department. Now, today is one of these days that we really struggle. Early this morning, the Queen Elizabeth Hospital and I believe also the Prince County Hospital were both looking at canceling surgeries because we didn't have beds. Lots of people in the emergency department, we didn't have any ICU beds to put a new ICU patient in. So there's a lot we have to do in order to try and become more efficient. We have to try and utilize all of the hospitals as well as we can to flow patients through the hospital, provide the best care that we can in the appropriate setting, which may very well be in your hospital. And as I understand it, I think that the intention is to continue with the patient population that we're sending up to you. So you will be continuing to care for them, and we really do need that, and we do appreciate it. I would also add that when you look at what's coming in the future with the demographic trends and the demands that are coming forward for the health system, we are all going to have to be looking very carefully at how we utilize every aspect of the healthcare system, whether it's home care, strengthening primary care, using all of the facilities appropriately. It's going to be absolutely paramount because we're facing a very scary situation in the future. We are struggling now, and we'll struggle more in the future. Anyway, thank you for your hospital, for your physicians.
I just want to ask you, is there a number of closed beds in QEH that could be utilized?
Right at the moment, all the beds that we have that we have staffed are open. The question arises periodically. So just let me explain. The question arises periodically about ICU beds. We could open a couple more ICU beds if we had the staff. We have 238 beds, and we don't have free vacant beds right now. We've gradually opened beds in various areas. The 238 beds don't include our nursery beds. So if we wanted to open up, let's say, another 10 beds to do something with, we couldn't do that right at the moment. We would actually need to do some sort of renovation, try and figure out how to do that. There may be beds, and then let me just explain. There may be beds closed on a given day, but it is because of a particular reason, such as a patient with an infection. We don't have enough private rooms for those patients. We might have to put them in a semi-private room and close the other bed if it's required for their infectious condition. So in those sorts of circumstances, we can have closed beds. As well, this month we're struggling with the number of nurses on our surgical unit. So there may be isolated days when we have beds that we can't put patients in because we just don't have enough nurses. Again, you may have heard of the slowdowns, the surgical slowdowns at Easter and at Christmas, and we have them in the summer where we do close beds for again, for staffing reasons. So it kind of depends on what bed you're talking about and what day. But in theory, all of our beds are open.
Dr. Henderson, hello. Dr. Henderson, thank you very much for coming. I'm sorry to hear about your situation this morning. We did have beds today. Why didn't you send some?
Right.
No. I'm assuming there were legitimate. I'd just like to know the process, like what happened, because the process already. We've had memos all year telling us that we should accept patients, and we're happy to. I don't think Dr. Barrow or I have ever turned one down. So that part's already really in process. I'm wondering kind of what happened, why they didn't come.
You've been very helpful when we ask, and usually there's a bed or two available, and so Surrey is unquestionably one of the places we turn to try and move patients. So I think we need to do a better job of identifying the patients that can go. There are times when our patient flow coordinator will say that she has been all over the hospital, and there just isn't anyone that is suitable for a variety of reasons. The physician at the Queen Elizabeth Hospital doesn't feel that they want to see them transition to another physician just at the moment. They want to be able to follow them, or they require other consultative specialist services. They're being lined up for a procedure, like an endoscopy procedure, something like that. Variety of reasons like that. But I think that it has to be more top of mind, and I also think that we need to prepare our patients better so that we don't face the resistance that, to be honest, does sometimes prevent us from sending patients that we think could go. And that is something we struggle with and we need to improve.
So with all due respect, my thought is this plan may not solve that problem, because we already have the beds.
And I'll just say that I don't think it's going to be a massive help either. I think it's an incremental process, but we already use you very effectively right now, and I wouldn't actually disagree with your statement entirely, but I think that there are incremental gains we can make. Unit 6 was closed many, many years ago. I don't remember how many, but many. It was a full ward. It was closed many years ago. Now we house our social work department there. We house our internal medicine specialists there. And so we actually sort of considered a little while ago, well, what could we do to open up some beds in Unit 6? And in the future, maybe that's what we're going to have to go with. But it would actually be quite expensive to convert it back to a nursing unit. We'd have to put the call bell system in, that sort of thing. But that may be where we have to go in the future. Let's see now. Our wards are basically, our wards were basically designed as 40-bed wards. So I'm thinking it must have been about that. Well, we've closed a number of beds in the Queen Elizabeth Hospital over the years compared to many, many years ago, and that's exactly what has happened across Canada as well. As patterns of care change, we've moved more to ambulatory care, to day surgery, that sort of thing. So it has been appropriate in the past. In the future, we'll have to see what the situation is.
Okay. Thank you, Dr. Henderson. Okay, thank you.
Thank you. Thank you for that, Rosemary. But rural PEI is not the solution, and we're not the problem.
Yeah, right on.
Minister Curry, I have great respect for you showing up here tonight, but you're too late. You should have done it before this. You should have came to the frontline workers. Frontline workers, I mean nurses, paramedics, doctors. I've talked to the nurses. Mr. Speaker, when I asked you a question in the House last fall, you never even knew our walk-in clinic was closed for 2 months. You know, you say you're connected with all islanders. I talk to the paramedics. I talk to the paramedics pretty near daily, on a daily basis. One of your own MLAs stood up in the House. Rural hospitals. We got to keep our rural hospitals. We got to keep the people. We got to keep the people in rural PEI. Without rural PEI, and he stood up in the House and said this, Charlottetown can't survive. They come to Charlottetown, they come to shop, they come to visit, this is where they spend their money. And he stood up in the House, and that's what he said. Minister, do our doctors want our hospital to close? No, they do not. Do our healthcare workers, Minister, want our hospital to close? No, they do not. Does the people of our community want our hospital to close? No, they do not. So, Minister, why are you so right and all these people are so wrong? Minister, I'm not going to hold you up. I know there's more speakers, and I got you back on the floor of the House. And I can hold you there. But, Minister, you were the Minister of Education. You came into our community and promised a new K-12 school. It was the best thing that was going to happen in Eastern Kings. You sold it. You tore our schools down, and look what we got, a broken promise. Your Premier, Minister, he campaigned on a doctor for every islander. Broken promise. So, Minister, why should you come into our community and these people begin to believe you what you're going to do here tonight? Why should they believe you tonight? Minister, I'm not going to take up any more of your time. That's all I got to say, and I'll see you back on the floor of the House. Thank you.
Nathan?
First off, I'd like to say I think we should order some pizzas. We're going to be here all night. I'd imagine Minister Curry has a credit card on him that he can use. I was going to come up here and ask that we do extend the time and answer all the questions, and I'd like to thank the Minister for allowing us that to happen. Because we've got some questions that need to be answered. While the Minister makes much of his and the Premier gives his presence on the national stage of our national health care, I note that the Canadian Medical Association is conducting extensive public consultations as a part of its health vision, a step the Minister continually refuses to take. Ontario, among others, have elected health boards. PEI does not. Currently, ambulance services is simply unsafe and is inadequate for the Minister's proposal. Inadequate, and the Minister's proposal isn't enough to make it safe. Eliminating island-wide hospital access will make it more unsafe. Saskatchewan went to a super hospital model, but now is building hospitals in rural areas. Pardon me. So my question for the Minister is this. Are you going to come good on Premier Giz's promise to have a family doctor for every Islander and to reopen ER service in Surrey? And will the minister stop the proposal and enter into a model base on medical studies, sound economics, and consultation with the people? I'd like an answer to those questions, please. And I don't mind asking them again.
Thank you very much, Nathan. And certainly, as I shared at the start of the meeting, my priority as the minister is to make sure that we're using all our community facilities. There's not a bed being closed. There's not a hospital being closed. And the objective here is to make sure that we use all our resources to the full potential. And one of the things that I have the responsibility and the challenge to do is I have to look at healthcare from all across the province of Prince Edward Island, which we all know. One of the realities of it is whether I deal with somebody living in Stanley Bridge who's got a 40-minute access to a service, or somebody in Borden, or somebody in Surrey, or Montague, or Charlottetown. The objective is to use all our facilities to the full potential. And if we have one vacant bed in Surrey, if we have one vacant bed in O'Leary, if we have people on stretchers, we need to use all of our assets to their full capacity. My objective is to make sure that our facilities and communities are fully functioning on all cylinders. My objective is to make sure that we have timely, quality access to emergency response services, that if a 94-year-old lady in this community needs high subspecialty acute care services, they're going to get them to the hospital that provides those services in a timely fashion. They're not going to wait in an emergency room. They're not going to wait long times for a bed. And at the same time, and as I said in Charlottetown and Saturday morning, if people can drive in, we can drive out. And at the end of the day, it's all about a provincial system, and we're 146,000 people. We're the same size as Peterborough, Ontario, and we have tremendous assets here in the province of Prince Edward Island. And I'm not going to sit up here and say it any other way, but the bottom line is there's huge pressures facing this province, and I'm just being frankly upfront with that. We've got an aging population. We've got a population base between 50 and 70 that are moving through the system. 1 in 5 Islanders are turning 65 by 2020. We have to make sure, and it'll be maybe another minister, I'm sure, and another government coming after that'll have to make decisions, just like governments have in the past. Healthcare has evolved. 30 years ago, they were delivering babies at the O'Leary Community Hospital. Today, that doesn't happen. Healthcare is changing. The way the family medicine is working, we all remember family doctors that used to do house calls. Family doctors today want to work 37.5 hours a week. They're more interested in work-life balance. That's some of the challenges in respect to recruitment. We've got huge resources on the table. I'm writing checks for graduates to try to get them into rural PEI. $160,000 to $170,000 to come into our communities. Right now we have 4 vacancies in the province of Prince Edward Island. We do have 95% of our population that does have access to a family physician, but that's not enough. I recognize that the role of the nurse practitioner here in the community is effective. She's skilled, she's talented. We will be graduating the first class of nurse practitioners who are working currently in the healthcare system, and we'll be offering those hopefully positions in communities all across Prince Edward Island. We want to make sure that we have the best access we possibly can. We want to make sure that whatever range of illness or sickness that we have a healthcare facility, whether it's in Surrey, whether it's in Montague, whether it's in Charlottetown, Summerside, whether we anywhere in the province. If we need to airlift someone to the QE2 in Halifax, we're going to get them there. If we're going to need to provide services for a mother who's delivering premature twins, we're going to make sure they get to the QE2. This is not just about, from my perspective, this is a very important conversation tonight. And I hear everything that's being said tonight, and I get it. But at the same time, I have to step back from this conversation, and I have to look at the role of all facilities and to make sure that this province has quality access to a service whenever they need it in the appropriate situation. Whether that's here in the community of Surrey, whether that's for a cardiac arrest in Charlottetown, coming from Surrey, if that means somebody that needs neurosurgery is getting airlifted to Moncton, if that means that somebody who needs vascular services gets to Halifax. So all I'm saying is that we need to use our assets and identify and try to balance between the pressures that are on the system. We don't have oil. We're not rich in natural resources. But we do have a system that has a lot of potential, and I think that we can continue to use it continuously to its full potential. So thank you.
Like I said, I wouldn't mind asking again. Are you going to come good on Premier Giz's promise to provide a doctor for every Islander and to reopen ER in Surrey? You can answer that one first if two at a time or too much.
Thank you very much. And obviously the challenges with emergency room services, you need physicians that want to work emergency room coverage. And if we have a physician, obviously we're seeing the same challenge up in the Western Hospital, and we're seeing the model that was implemented. The government, the NDP government in Nova Scotia is looking at the CEC models all across the province of Nova Scotia. Actually, they have opened up their 8th. Spring Hill, we had the opportunity to see the facility. It's working. Paramedics, advanced care paramedics and RNs are working in the facility and providing quality care, allowing the physicians during the day an opportunity to see the patients. We are looking at that model right now. We are going to implement that in Mile. I didn't make any commitment other than that. I want to make sure that model is successful and it's working in the community hospital in Alberton before we look at expanding that. But once again, it's about expanding emergency room services. And we have assets, whether it's an advanced care paramedic, we've got advanced care nurses, critical care nurses that are trained that can provide services outside of the scope that they've traditionally been allowed to work. So the response to the question is I am committed to working at improving emergency response services, better access to family physicians. We have 2 here. I remember coming to Surrey in July of 2007 when we were at the brink of losing all our family physicians. We rebuilt that physician complement back up. I believe I worked closely with the Toms. We trained, educated his wife who was practicing. Once she finished her agreement, they went back to their community, I believe, in Toronto. And those are some of the realities of the pressures that we're under. The residency program has proved to be successful. We're trying to continue to look at ways that we can get physicians. We don't need physicians in Charlottetown and Summerside. Right now in this country, they're graduating 3,000 Canadian trained physicians, not all family physicians, and 700 Canadians are being trained in international schools. And doctors are working longer, they're extending their careers. So the supply-demand thing is changing dramatically. So within a year or 2, we'll have no vacancies in the Charlottetown, but hopefully we'll be able to continue to make sure that we need physicians in rural PEI. I get that. We're also talking to the Canadian Association of Assistant Physicians, looking at ways and what their skills are, what their scopes are, and looking at ways that we can provide services in communities across the country. We need services in rural PEI. And I'll stand by that, and I'm committed to that. We cannot continue to provide all services and everything at the Summerside Hospital and the Queen Elizabeth Hospital. We just can't do it. And right now we're at max. But I know that when somebody in this community or any other community outside Charlottetown, Summerside, needs access to a acute care bed for a surgery or a service, we got to make sure that that bed's available. But they're not going to be staying, if they're only allowed to be there for a few days, we need to make sure we get them out so that person that's waiting on the stretcher can get into a bed to recover. And as I said to my mother the other day, if you go for a hip or a knee in Charlottetown, you may very well end up in Surrey and for your post-op recovery. So that's just how the system has to work. So thank you.
Nathan.
So.
Excuse me, Nathan. I'm just looking at the folks that are lined up there, and I'm wondering.
The minister said we have all night. Do you need me to ask you again, or? So it was a no then. Okay. So will the minister stop the proposal and enter into a model based on medical studies, sound economics, and consultation with the people? Yes or no?
Thank you very much, Nathan. And, when we talk about engagement and consultation, certainly that's important. There's no question. and I'm committed to coming out to communities. And these are not easy meetings, and there's levels of frustrations, and I can respect that and appreciate that. There has been a number of discussions in respect to community health care, and obviously Health PI has led some of those initiatives, obviously with their survey that went out to 62,000 homes. 12,000 Islanders responded to that survey. There was also focus group discussions in 5 communities as well. Plus there's access to information that they report to online and so on. So certainly there is conversations and there is discussions that are happening, and there has discussions that have happened. So, and I'm here tonight to listen to the concerns, and obviously as Mr. McPhee alluded to, I'm sure that we'll be hearing from him shortly with a group of concerned residents to continue. These investments and these changes and these realignments, nothing's been closed, nothing's been shut down, no beds have been closed. We're not closing any facilities in Prince Edward Island. Right now, we're just looking at using all our resources to their full potential. And we're going to continue to work hard on our recruitment initiatives. We're going to find creative ways to expand scope of practice and look at new models of healthcare delivery here in not only in Surrey, but in communities all across Prince Edward Island. So that's my response.
Mike?
Well, thank you very much. My name is Mike Redmond. I'm the leader of the NDP. So I put that out there just to make sure that, thank you, so that there's no misinformation, and I am a part of a political party. So I'm going to start off, and I am going to disagree with the minister. I really feel that PEI is rich in natural resources. It's the people of Prince Edward Island. So one of the things that doesn't get talked about a lot, and it's something we really need to consider, is the stress that gets put on communities when there's so much information. And that's not being talked about. And governments, past and present, have successfully not communicated with communities and stakeholders, and that's us in the room. We have an aging population, no doubt about it. Guess what? That's not new. We have the highest obesity rates in Canada. We have 1 in 4 children living in poverty. 17,000 people living below the poverty line. We have a food security issue. These are statistics that we should not be proud of. And these are determinants of health. But not once in my lifetime, 44 years, have I heard a government say that this is an important issue. We are going to address our children, our families, and our communities. And what's more disturbing to me than anything is the lack of leadership by the Premier of this province. I never see him in rural PEI, ever. Right? He was a no-show on EI, all of those meetings. He'll be a no-show guaranteed on the health care changes because he puts the ministers and the rest of the MLAs up front for cannon fire to the general public so he can stay in Brighton. And there is a comment I'll make about doctor recruitment. I was a coach before I joined the political realm. And I coached a young girl at UPEI who had applied for medicine at Memorial. Not once did anybody from Health PEI communicate with this girl to see if she wanted to come back to PEI. Not once. So that's problematic in its own right. And I think a lot of the questions were already answered, and I appreciate everything that everybody said. And I really am very, very proud when I come to a small community like Surrey and see the turnout of the people. And I know Flossie McDonald's behind me, so I'm not going to take up too much of your time. It's like watching this hour as 22 minutes when she hits the mic. Right? So I won't try to stand her up here tonight. But I want to give you a quote, and I think we've come to a decision to make in our lives. We need to decide, as an island, putting politics behind. Not every 4 years do we make decisions. We need to make long-term decisions that affect our families, our children, and our grandchildren, and their grandchildren. We have to think about the future. We have to make decisions that impact the fishery, our farming, our tourism, and most importantly, the people in our communities. Article 25 of the UN Universal Declaration of Human Rights, and this, in my opinion, is a human rights issue. Everyone has a right to a standard of living adequate to the health and well-being of himself and his family, including food, clothing, housing, and medical care. I want you to consider the choices this government has made over the last several months in terms of the HST and exemptions. How does that impact food? How does that impact clothing? How does that impact housing? And most importantly, what are impacts we're making on our healthcare system? Thank you very much.
Good evening, everybody. Mr. Minister. And I want to we need to lighten up here a little bit, I guess, but when I come in here tonight, the numbers show that we have more than one person here for every $1 million worth of health care costs in Prince Edward Island. So, Mr. Minister, this is a chance in a lifetime, and it's better than $1 million. You know, so now we have all the opportunity in the world to make things different. And with that, we can make things better. If we go back a few years here, when we had a meeting at the Parish Hall in Souris, an announcement of the closure of the ER, after the meeting was over, and I'm so serious and I'm so sad to have to say this, we learned how much we were misled by the officials that gave us the problems with health care. And, you know, I don't keep things in me forever, but when you're misled by the people that you trust the most with the most essential service, my gosh, it's hard to let go of. There's people here lined up clear down both sides, clear across the back, that volunteer and give their services to this community every day. I came here from another province, from Prince Edward Island, a number of years ago, and with that, I learned about the expertise that's here and the talent, and people don't show their credentials. They have the common sense and the devotion to make things happen. You know, earlier that we don't have oil, I guess you mentioned to her like that. My gosh, we have everything else. Now, if you know, now, I'm going to not get emotional and get on with a couple of questions. You've had a lot of hammering tonight, and it's going to take a lot more before I think that we can have some change. And there's a lot of you can say whatever you wish, but sometimes when your ship is sinking, you have to drown the crew, and you're getting. I'm really concerned that you're getting poor advice from some people. And I know you're not getting poor advice from all people. Shortly, not too long ago, Dr. Reed talked about the good old days when they could recruit people. And it made me think of, just after speaking with people that are knowledgeable of the health care, I'm told, I said, can we not get doctors to come to Souris if we wish to open our emergency? And the answer was emphatically clear. Yes, Alvin, but you have to have an emergency to get doctors. Young people come out of, I'm going to say medical school. I may slip up on a terminology. I was going to say residence or intern, but I think I think people know what I'm referring to. They want to get their teeth into the real aspects of medicine. And they have medical loans to pay off. And they want to practice medicine. And they want surprises at the door when they open it. When people come in with their family members with health issues or the ambulance lands. And yes, I muchly agree that your specialist in Charlottetown is where you need specialty medical care. And with the right communication in your sector, if people communicate well, you will have that. And there's doctors who spoke here tonight and healthcare workers, and they all agreed one way or another, or without saying it that clear, that that's what we needed. Second of all, whatever it is, I don't need it, but
you actually do.
so So there's more questions, and I'm going to sit down, but we had, what's the protocol of how patients are admitted from one hospital to another and transferred, but I think that was answered tonight, and there's more people on the floor, so I'm going to sit down, but I want to say, we don't grow all the potatoes in the world in Prince Edward Island, we just grow the best. And I also know that we can have the best health care, and we need to get the cost out of it. And that's a huge challenge. And I respect that. And I would like you to refer to the rural areas for recruitment for doctors. And I can convince people to come to Souris. I don't have the heart in me to convince them to come to Charlottetown. Thank you.
Hi, I'm Flossie McDonald, for anyone that doesn't know me. Hi, Doug. I'm not going to talk tonight about all the stuff I talked about the other night. That will only keep you here too long. But for anybody that doesn't know me, I worked back in Souris Hospital many long years ago in the 60s, between 63 and 70, for 70 years. I'm going to do this very briefly. There was 2 people on, 2 nurses on each shift, 3 in the daytime. We had 1 doctor. We had a second one for a little bit here and there, Dr. Kennedy Sr. and Dr. Earlham. During that time, we did everything. We were the community. We were the lifeline to the community. People came to us with their babies when they were sick. They came when they were having a miscarriage. They came when they had broken ribs. We did set legs. We put on casts. We did all of those things with 1 doctor and 2 nurses on. We had emergencies come in 24/7. We were open at that old hospital 24/7. People came all hours of the night. We had no clinic back then. Our doctors, our only doctor, Dr. Kastner, had office hours during the day. He worked all day in his office, and he was on call all night when we needed him. He didn't always come to the hospital, but we knew he was there. We could phone him if we needed him. I remember one, and I'll cry again because I think this is so sad that we're here at this stuff these days. I could stand here and tell stories till the cows come home, and it's too late. But I remember a young person coming in one night with a child that was convulsing because it had a high fever. And she thought it was the end of the world. This child was dying. It probably was. But anyway, we knew what to do. We sponged it down. We called the doctor. He said, admit it. We put up a crib about 10 o'clock at night, 2 of us together, while all those other things were happening. And we took care of that child. That's what the community is all about. We didn't have to send it to Montague. We didn't have to send it to Charlottetown. We need our re-Arab kids back, and we want them back now. We don't want to wait for those. The one thing I didn't talk about the last night I was here was the ambulance. And I'm glad that this young gentleman spoke tonight about Gary. We had an ambulance that was 5 minutes away from the hospital. It was 24/7. They were there all the time. We needed them. They were within 5 minutes of the hospital to take somebody that needed to go farther than we could do anything for them. Lots of times there was only 1 person to go in that ambulance. And we were in the community as nurses, called in the middle of the night or the late evening to say, can you go to Charlottetown with Gary? He needs somebody. And off we would go. And I remember distinctly of sitting on the end of the wharf with Gary one day while I was waiting for a dragger to come in, where there was a man had his arm mangled and his shoulder mangled, and we were there for him to go to we stopped at Souris Hospital, got him a shot, and off we went to Charlottetown. Now, I didn't do too much for this man. except perhaps hold his hand and tell him he's going to be okay. But I did go, and I was there for Gary when he needed me. That's what community is all about. That's what we're missing out on now. We need this kind of... We need this kind of a community where people, honestly, Doug, I get up in the morning and if I see in the paper anymore or I hear on the news anymore about the baby boomers, I'm going to go nuts. I am the baby boomers. So are you. Okay. I'm really not looking for a bed in the manor yet, and after tonight, I'll probably never get one. I am more concerned about our young people in this community, the young mothers, the young fathers, my grandchildren. What happens if they have an accident? What happens if they have to go to Surrey Hospital right away and there's no doctor there to take care of them? I listened to Dr. Henbest this evening here, and he's gone. I know exactly what he's talking about. We need a personal touch. The other thing, Doug, if I hear this anymore, I'm going to go nuts too. And nobody said much about it tonight. This 811, honest to God, I get tired when I think about it. To think that somebody is going to... I'm not saying that the person on the other end of this line is not educated and not smart and perhaps a hell of a lot smarter than I am. But that person is not there to touch and care for the people that are right there with us. Do you know what it reminds me of when I hear tell of 811? I have a stove from Sears that has extended warranty on it. And it has digital all over everywhere. And every once in a while it takes a turn to farting and going on and it's going to die on me and there's blinking and whatever. And then you go to the book and it'll say, flip the lever, and if it doesn't work, call this number. Emergency. Call the emergency, you get this nice girl. You do get a body. And she'll say, do this, do that, do the other thing, and she's troubleshooting. And then she'll say, well, no, that's not working. I'll have to send somebody to fix it for you. Where do you live? How far is that from Charlottetown? Oh, well, you may have to wait until there's somebody else in Surrey that wants something done too. So every day I get up and hear this 811 or read it in the paper, I'm starting to feel more like a stove every day. Honestly. The only thing I'm going to say, Doug, and I know you personally, and I know you're a good person, and I know you have compassion and all that, we want you to sit down with us. We want to work at getting our emergency back in Surrey. We want to keep our acute beds. We have two wonderful doctors here right now that want to stay here. I heard one of them say, I'm not going anywhere unless I die. And so that's a wonderful thing to hear. We also have a locum in the community tonight, so we have 3 doctors. And I heard rumbles, Summers, that there's going to be a 4th. So I look at all the people that's gone west. And I think of when I worked back in 1963 or whatever, there was more people in this community then. And we, with 1 hospital and 1 doctor and 2 nurses, took care of them all. So what's going on with this? I mean, there's not as many people here now as we used to have. So we should be able to do something with 3 doctors and all the wonderful nurses and people that we have in the system that we're in. You know what? Doug, what you're putting in front of us is worse than what we had back when I was working in 1963. I'm looking at Wes, and he's over there, and he's yawning, so I'm going to bring him to life. With all the talk about money, 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 and statistics to hear tonight till the cows come home, and there's so many people that don't know about statistics, and they don't give a shoot. But anyway, I will tell you, back when I worked in Surrey Hospital in 1963, I worked 8-hour day every day that I was there, and that would be 1 day off 1 week and 2 the next, which would mean a day and a half a week, okay? 2 weeks, I get paid $150, okay? We did the same work then that these people are doing now. That, do the math, as Alvin Keenan say, do the math on that. It's something like $3.50 an hour or something like that. And we worked our asses off. So I don't really have too much, whatever, for these people that are complaining about no money. And as far as the beds, for us boomers here that's going to get old and need a place to sleep, build some more beds on the manor. Find some money. We don't need to give up our acute beds. The place was designed up there to build onto. So get with it. Okay? Anyway, I'm saying when I'm standing here, I'm talking to all these people. It's like Father Paul. Where is he? He's gone. Okay. Talking to all those people when I should be talking to you people. You're the people I should be talking to. You people over there should be talking to. It's very important that we keep what we have. Don't take it from us. We work too hard to get it. We got our manor. We got our detox. The only time that I remember the hospital ever having its doors closed to anybody was to keep somebody that was in the DTs inside. So they wouldn't go out and fall over the bank on us. And that's the truth, and it is. We had to lock the door one night because somebody was running around and I thought he was going to be over the bank on us. So that is all I have to say. I thank you.
No, Minister, my name's Roddy McLeod. I live up east here, and I know you're from the Parkdale Reunion. Oh, sorry. Okay, your plan tonight about what you're going to do, I heard it all. And you gave an example of that 94-year-old woman. Well, I'm here to give you another example tonight. My mother, in February, she ended up in the hospital, in the emergency room in Charlottetown. I don't know how many days she was in the emergency area, and then they finally moved her to Unit 3. They did a lot of tests. They found out she had bone cancer. And that night she took a seizure. Never took a seizure in her life. The call was all in. 3 days later, that was on a Thursday or Friday night, I think. On Monday, we went in there, and the doctor came along and said, we're going to send her back to nursing home. She was in constant pain, needed constant care, and we were there 24/7. And they came to us on Monday and said, we want to send her back to the home. I wasn't taking care of her. She needed constant care. She was dying. And they said, we want to send her. And we said, no, she's not well enough to go back. And she won't have the care that she needs right now. She's on her deathbed. And they said, well, that's the best we can do. We need the beds. So if you don't have the beds now, I don't know how you're going to get them then. But anyway, we had to call Souris. Thank you, God. Souris Hospital. Dr. Hembeth, thank you very much. And within the hour, she was on her way to Souris. She died at 8:23 the next morning. And she had lots of good care, well looked after, in a hospital that cared. And she was going to be kicked out of Charlottetown Hospital. So don't tell me your plan is going to be better. It's not going to be better. We've got a good plan now. Let's develop it and make it work.
Minister, the last word is yours.
Okay, her short. Okay, I'm still standing, and I'm not in the ground ambulance. Didn't have to go out the door. I guess, first of all, I just want to thank everyone for coming out tonight. And as I said at the start of the discussion, healthcare is a very, very emotional, personal issue, and it runs deep into communities across the province of Prince Edward Island. And as the minister part of the challenge I do have in respect to this conversation tonight, I have to have other conversations, not only in Charlottetown and Summerside, but other communities across Prince Edward Island. I want to thank you for coming out. Obviously, I'm going to have more formal conversations from groups of community representatives, and I look forward to those conversations. But in the interim, as the Minister, we're not closing beds, we're not closing hospitals, we're going to continue to recruit aggressively to fill your complement. We're going to continue to find ways to improve your emergency response access. We're going to improve your ability for access for mental health and addictions and long-term care. And I also want to also acknowledge that when somebody needs a service that's not provided here in your community, whether it's in Halifax or Moncton or St. John or Toronto or Vancouver, they will get that service. So thank you very much for coming out tonight. I appreciate your questions and your courtesy and your respect. Thank you.